Part 3 of this course relates to myxoid lesions. Now, myxoid is a term which we tend to use quite a lot as pathologists, but it has a definition which means a lot of things to a lot of different people. In general, the term refers to an appearance which is mucin-like, but in general we use it to cover a lot of different appearances that we see in a number of different lesions, as you can see perhaps in definition number 2. And in general, it's pale to lightly basophilic stroma on H&E with often few cells present other than a number which are indicated there, and it is seen in quite a number of different lesions. So that brings us to case number 3, which is a 40-year-old female who has a firm swelling of the mandible between teeth 28 and 29. There is also an associated radiolucency in the mandible, and at surgery it was reported that the lesion was not cystic. So here we have our lesion, quite difficult perhaps to see in this case, and very difficult to identify, but it's in the mandible just to the right of center. And then this is the tissue which was retrieved from that. There is some surface epithelium which is present, and then a lot of tissue which has that grey, slightly basophilic appearance to it that we described earlier. So this, at higher power, is the histological appearance, and you'll be able to see that in slide number 3 yourselves. And it has a collagenous element to it in terms of the collagen fibers that you can see, but overall there's a lot of ground substance here, and it has that basophilic, rather myxoid appearance that we associate very well with that term. And here at slightly higher power, and it's very evident the paucicellular nature of this, occasional inflammatory cells and occasional fibroblast-like cells as well scattered throughout the lesion with the basophilic background and the collagen fibers. Some areas are slightly more collagenous, as you can see here, and also contain blood vessels. And in this case, the final diagnosis that we arrived at was an odontogenic myxoma. So odontogenic myxoma and fibromyxoma are lesions which comprise a reasonable proportion of odontogenic tumours. After ameloblastoma, in most series, they are the second most common of the odontogenic epithelium, more common in females, and tend to be in those in their third decade as a mean age. Most are slow-growing painless swellings, and there is a significant propensity to recurrence. The majority of them on radiology are radiolucent and are multilocular, with the soapy bubble appearance of very small locules, and there is effect on the surrounding teeth, either root displacement or resorption, and they cause expansion with cortical perforation in a significant proportion. For further reading in that, to look at Cherkanovich and Gomez's paper is very useful. The histogenesis, however, is disputed. And although it is generally said that they have arisen from the dental mesenchyme, it doesn't really seem to resemble dental papilla very much, but may more resemble dental follicle. There is some circumstantial evidence of it being odontogenic in origin. It tends to occur in the tooth-bearing part of the jaw and occur in younger patients, many of them in their teens, which may indicate some association with tooth development, and similarly when there are missing or unerupted teeth associated with that. And some of them do contain a small amount of odontogenic epithelium. However, there's not entire agreement in the literature on that, and some authors believe that these are circumstantial evidence, and this has been overstated. The tooth-bearing jaw, I think, is a very useful feature to bear in mind. The Sheffield experience of that, we had a number which we reported in an overall survey of our odontogenic tumours a number of years ago in OOO. And you can see that these lesions extend through either the mandible or the maxilla. Most of them are in the mandible, but they can be rather extensive. And a proportion of them, particularly in the maxilla, are relatively less well defined as far as their site. And our most common age was very similar to those in the large survey. So here we have a very large odontogenic myxoma, which is present in the right-hand side of the mandible. It extends from around about the parasymphysis to the sigmoid notch coronoid process area. And you can see it is a multilocular radiolucency. It's relatively well defined, but it's not corticated, and there is marked displacement of a third molar tooth and root resorption, particularly of the lower second molar tooth. Here is another less spectacular example in the mandible, and in this case it is around about the area of the bicuspid teeth. Again, a multilocular radiolucency, relatively well defined but not corticated, and in this case there is marked displacement and tilting of the teeth associated with this radiolucency. On sectional imaging, again, you can see a lesion, and this accentuates the issue which I indicated about cortical perforation and expansion. These do tend to be expansile lesions, so you will get significant buccolingual expansion, and commonly they will perforate the cortex of the jaw. Some of them do present in gingival lesions as peripheral lesions, but very often it's the peripheral extension of a central lesion. And this lesion, which obviously clinically has quite a wide differential diagnosis, was an odontogenic myxoma, and it was associated with a lesion which was present within the bone and had extended into the soft tissues of the gingiva. It is in there just in front of this second bicuspid tooth on the left-hand side of the mandible. As far as the appearance of these lesions is concerned, you can see that this is a multilocular radiolucency. And in this resection specimen, you can understand why the term soapy bubble is used. The small locules tend to look like that, and the gross image demonstrates the expansion which is seen. Histologically, they tend to look very much like the case that we have shown. They're not encapsulated. They tend to percolate through the tissue spaces with this loose and myxoid tissue, as you can see in the photomicrographs. It tends to be quite hypocellular. One characteristic feature that we often see are bony septae, and that relates very well to the radiographic appearances. Some areas have thicker collagen bundles, and others have epithelial rests. From a histochemical point of view, Alcium blue positive, which is picking up the ground substance, and PAS is often negative. So here's another example of a lesion with very similar histological appearance. Here's another example at the more fibrous end, and you can see that there are bands of collagen separating areas of more myxoid tissue. The struts of bone, the septae, which are present often to be seen on the radiograph, are present, and there can be quite a sharp distinction between more myxoid areas and more collagenous areas within the same lesion. Areas of calcification or odontogenic rests are also present to variable degrees. But the main issue largely arises in the differential diagnosis, and particularly when we're using a number of rather circumspect and inexact evidences for an odontogenic origin. So we have to bear in mind that there is myxoid degeneration in other tumours which may present in this way, for example, including a myxoid neurofibroma. And to some extent, some have reported that the nuclear morphology, including binucleate cells, favours an odontogenic myxoma rather than a neurofibroma. But there are others, myxoid lipoma, chondromyxoid fibroma, and so on, and other differentials which come into play if the lesion is predominantly fibrous. As I indicated, I think, although circumstantial, the occurring in the tooth-bearing part of the jaw is helpful. Also, it is useful at times to do some immunohistochemical analysis of these tissues. Vimentin is almost uniformly expressed, as is asthma. S100, the literature is rather confused and not particularly helpful on, and they should be cytokeratin negative other than the epithelial rests. From a cytogenetic point of view, there has been some limited analysis done, and some have mutations in PRKA3A1 and microduplication of certain parts of chromosome 1q have been reported, but these have not been confirmed. What about peripheral odontogenic myxoma? Well, we saw a lesion which had extended from the central component to involve the gingiva, but true peripheral odontogenic myxomas seem to be really very rare, and there is some dubiety as to whether they actually are a real individual lesion. When they have arisen and have been reported in the literature, there's wide clinical and histological differential diagnosis, which to some extent is very similar to the central lesions. But you also should consider others such as a soft tissue myxoma and the interesting condition which is seen in the oral cavity of focal oral mucinosis. Here's an example of a lesion which we discussed for a while as a peripheral odontogenic myxoma or focal oral mucinosis. In this case, PAS negative, S100 negative other than some nerves, and predominantly vimentin positive. So the immunohistochemistry is not really particularly helpful in this case. Focal oral mucinosis is sometimes seen in a variety of sites in the mouth. It's a collection of rather myxoid tissue, quite commonly seen in the gingiva, which may lead to this confusion with a peripheral odontogenic myxoma, and has histological features which in many cases are very similar. Odontogenic myxomas have been reported to have prominent reticulin fibers which are absent in focal oral mucinosis, but I have not myself had any experience of using that in diagnosis. And of course, in terms of focal oral mucinosis, there is some conjecture as to its pathogenesis. So as far as myxoid lesions are concerned, here's the summary. Odontogenic myxoma is the second most common odontogenic tumour, and diagnosis is essentially a diagnosis by exclusion with a wide differential diagnosis to work through, and it also includes very careful paying attention to the clinical and radiographic appearances, as with all of these odontogenic lesions.